Hello class, today we'll be talking about schizophrenia and psychiatric disorders. Schizophrenia is a serious mental disorder and is typically diagnosed in adolescence or young adulthood. So the peak age for men is 55 to 25 and for women 25 to 35 for the diagnosis. Schizophrenia causes distorted, bizarre thoughts, perceptions, emotions, movements, and behaviors. It is a noted disturbance in the perception and thought process of the individual. These disturbances causes a severe deterioration of social and occupational functioning. Schizophrenia is diagnosed by a classification of certain symptoms. So, hallucinations, delusions, and extreme disorganized thinking and behaviors that impair their daily function must be present in order for this diagnosis. And usually, these positive signs of hallucination, delusions, and disorganized thinking is present for approximately about a month or less if they've received treatment early on. And this disease can be disabling. Okay, so let's talk about the positive symptoms of schizophrenia. So the positive symptoms are not positive. So you want to just remember that because this can get a little confusing. Positive symptoms are attributes added to the personality which are not supposed to be there. So these symptoms are not positive. The typical positive symptom of a schizophrenic patient is hallucinatory experiences, fixed delusional beliefs, and it tends to make them very upset and disrupts their everyday activity. From the outside, the person that's experiencing positive symptoms may just seem to be a little distracted, or they may seem like they're listening to something. And psychiatrists call this responding to internal stimuli. So here are some of the negative symptoms. So negative symptoms are attributes which are supposed to be present in the personality but are not. Negative symptoms refer to reduction of lack of ability to function normally. For example, the person may neglect personal hygiene or appear to lack emotion, doesn't make eye contact, doesn't make facial expression, and speaks in a monotone. Also, the person may lose interest in everyday activities, socially withdraw, or lack the ability to experience pleasure. So here we have several categories of negative symptoms. So affect, avulsion. Well, avulsion is just having the lack of motivation to actually get something done. Impaired interpersonal functioning and relationships to the external world, and psychomotor behaviors. Nature of schizophrenia. With schizophrenia, there is a severe deterioration of social and occupational function. This is key. So the symptoms impair the person's functioning, both socially and occupationally. In the United States, the lifetime prevalence of schizophrenia is about 1%. Premorbid behavior of the patient with schizophrenia can be viewed in 4 different phases, and we'll talk about those 4 phases on the next slide. The 4 phases of schizophrenia. Our first phase is premorbid phase, and your patient would present as being shy or withdrawn. They may have poor peer relationships.
They may be doing poorly in school and have antisocial behaviors. Then you have your predominal phase, which lasts from weeks to a few years. Deterioration in role functioning and social withdrawal may occur. Substantial functional impairment may occur. Your patient may appear to be in a depressed mood, have trouble concentrating, and may appear fatigued or complain of fatigue. And the onset of obsessive compulsive behavior, sudden onset of OCD may appear. Acute schizophrenic episode is our third phase. And in this phase, your patient will have active um, symptoms of psychotic episodes where they may experience hallucinations or delusions. And these um, symptoms of psychosis interferes with the patient's work, social relationships, as well as caring for themselves. And our fourth phase is our residual phase. So in our residual phase, symptoms similar to those of the predominal phase are present. The patient may have a flat effect. Basically, that just means they have a straight face. They're not making any facial expressions. And the impairment in this role is prominent. So that social and occupational functioning, those roles are impaired.
Types of psychotic disorders. So, brief psychotic disorder has a sudden onset. It may or may not be preceded by psychosocial stressors. This is characterized by delusions as well as catatonic features, hallucinations, bizarre behavior, and disorientation. This person will return to their normal level of functioning within a month. Then I have substance abuse or substance and medication induced psychotic disorders. So hallucinations, delusions are associated with it. Usually it's caused by withdrawal or intoxication. Psychotic disorders due to another medical condition. So this is also classified by delusions, hallucinations, and generally another disorder is causing that. So lab findings, medical history, physical exam, all of these things are important in diagnosing this psychotic disorder related to a medical condition. I have notes to see table 15-1 and table 15-2. So infection of the CNS could cause these problems, migraines, headaches. And then for catatonic disorder, this can also be caused by a medical condition, such as metabolic disorders. So anything affecting your liver, your thyroid, B12 deficiencies, neurological disorders, tumors of the brain, or traumatic brain injuries. And then we have our schizoaffective disorder. So the schizoaffective symptoms are accompanied by strong elements of symptomology associated with mood disorder, such as periods of mania and periods of depression or depressive moments. So in the periods of depression, this person will exhibit psychomotor retardation, suicide ideations, and then in their mania state, they may have periods of grandiose thoughts, euphoria, hyperactivity. They also will experience delusions and hallucinations. and they usually occur at least 2 weeks absent of the major mood swings or mood episodes. Schizophreniform disorder is when a client exhibits an acute reactive psychosis for less than the 6 months necessary to meet the diagnostic criteria for schizophrenia. If symptoms persist over 6 months, the diagnosis of schizophrenia is then given to this particular patient. Social and or occupational function may become impaired in this individual. Schizotypical personality disorder involves odd, eccentric behaviors, including transient psychotic symptoms. Approximately 20% of people with the personality disorder will eventually be diagnosed with schizophrenia. Catatonia, or a catatonic disorder, is characterized by marked psychomotor disturbances, either excessive motor activity or virtually immobile and motionless. Motor immobility may include waxy flexibility or stupor. Excessive motor activity is apparently purposeless and not influenced by external stimuli. Catatonic or catatonia can be seen in schizophrenic patients, people with mood disorder, or other psychotic disorders. Clients with a diagnosis of schizophrenia often experience delusions, and delusions are a fixed or false belief with no base in reality that occurs in the psychotic phase of the illness. Delusions are ideas that are not true. For example, people with schizophrenia might believe that the Secret Service is out to get them, or that the TV anchor is transmitting codes and messages through the television, or their food is poisoned, and they have no evidence of any of this, anything to support these beliefs. Delusional disorder is characterized by the presence of delusions and has been experienced for at least 1 month. Hallucinations are not prominent during this time, and the behavior is not bizarre. So let's talk about the different types of delusions. So we have erotomanic type, and the individual believes that usually someone of a higher status, is in love with him or her. So they think that someone famous or well known is in love with them. Then we have delusions of grandeur or grandiose type. So these individuals with grandiose delusions have irrational ideas regarding their own worth, talent, knowledge, or power. They may believe that they have a special relationship with a famous person, or even assume that the identity of a famous person. Grandiose delusions of religious natures may lead to assumptions of identity of a deity or religious leader. We have the jealous type. Jealous delusions center around the idea that the person's sexual partner is unfaithful. The idea is irrational and without cause, but the individual with delusions search for evidence to justify the belief. The sexual partner is confronted regarding the imagined infidelity. Then we have persecutory type and persecutory delusions, and this is the most common type. Individuals believe that they are being persecuted and treated in a certain way. Frequent themes include being plotted against, cheated or defrauded, followed or spied on, poisoned or drugged. Repeated complaints may be directed at illegal authorities. Lack of satisfaction, from which may be a result of violence towards the object of the delusion. And we also have somatic type. These individuals with somatic delusions believe that they have some type of general medical condition. And we have mixed type. When a disorder is mixed, delusions are prominent, but no single theme is prominent. All right, and that's it for delusions. When a client experiences a sudden onset of at least one psychotic symptom, such as a delusion, hallucination, disorganized speech, or behaviors that last one day to 1 month, they are considered to be having a brief psychotic disorder. So there is usually a unidentifiable stressor that precipitates this, or sometimes this is following childbirth. Shared psychotic disorder is when two people share a similar delusion. The person with the diagnosis develops this delusion in context to a close relationship with someone who has psychotic delusions, most commonly siblings, parents, and child, or husband and wife. The more submissive or suggestible person may rapidly improve when separated from the dominant person. Schizoaffective disorder is diagnosed when the client is severely ill and has a mixture of psychotic and mood symptoms. The signs and symptoms include those of both schizophrenia and a mood disorder, such as depression or bipolar. The symptoms may occur together at the same time or may alternate between psychotic and mood disorder symptoms. Some studies report that long-term outcomes for bipolar type schizoaffective disorder are similar to those bipolar disorders, while outcomes for the depressed type of schizoaffective disorder are similar to those of the schizophrenia patient. Recent research shows that schizophrenic patients have a type of brain dysfunction, and autopsies show a difference in the brain structure. The genetic factor theory study identical twins, and if one sibling developed schizophrenia, there was only a 50% chance that their sibling would the identical sibling would develop schizophrenia, even though they shared the exact same genes. And for fraternal twins, if one sibling developed a diagnosis of schizophrenia, the other sibling had a 15% chance of developing the same diagnosis. And they also studied their immediate family members. So this study shows that there is more than just genetics that play a factor in the development of schizophrenia, although they have found genes that are linked to the development of this disease. Scientists have been able to study the brain structure, which is neural anatomy, and activity, which is neurochemistry, of people with schizophrenia. Findings have demonstrated that people with schizophrenia have relatively less brain tissue and cerebral fluid than those without the diagnosis. And CAT scans have shown that people with schizophrenia have larger ventricles. So the frontal lobe and the temporal lobe have been associated with this diagnosis. And positive signs of schizophrenia have been associated with frontal lobe, and negative signs of schizophrenia have been associated with, I'm sorry, positive signs of schizophrenia have been associated with temporal lobe, and negative signs of schizophrenia have been associated with the frontal lobe. So it is unknown if there is some damage to these areas, such as a virus, autoimmune response, something that happened in utero, or trauma. Immunovirology is a new emerging research study that factors in the chances that a virus could have caused an immune response that altered the brain's physical nature, causing the patient to develop schizophrenia. So studies are still going on in order to validate this theory. In the past, electroconvulsive therapy, insulin shock therapy, psychosurgery were used to treat schizophrenia. But now, psychopharmacology is the primary treatment of the symptoms of schizophrenia. So there is no cure for schizophrenia. We are only treating and managing the symptoms. So antipsychotic medications are also known as neuroleptic medications, and they are the first drugs prescribed to help treat the symptoms of schizophrenia. Also, mood stabilizers and antidepressants are commonly used to help stabilize the patient's psychotic episodes or symptoms. In addition to pharmacology treatments, there are many other modes of treatment to help the patient deal with schizophrenia. So we have individual and group therapy, we have family therapy, family education, and social skill training that can be instituted for the client in both inpatient and community settings. Individualized therapy includes cognitive adaptive training. And cognitive adaptive training uses the environmental support, and it is designed to help them to adapt in their home setting. Individualized environmental support such as signs, calendars, hygiene supplies, pill containers, cues to the client to perform associated tasks. This psychosocial skill training was more effective when carried out during a home visit in the client's home environment than in an outpatient setting. Individual and group settings are often supportive in nature and giving the client the opportunity to learn social skills and to have some social contact and develop meaningful relationships with other people. Groups that focus on the topic of concern, such as medication management, use of community support, family concerns, can be very beneficial to the schizophrenic patient. Clients can improve their social competency and social skills training, which will translate to being more effectively functioning in their community. Family education and therapy are known to diminish the negative effects of schizophrenia and reduce the relapse rate. Although inclusion of the family is a factor that improves outcomes for the client, family involvement is often neglected by most healthcare professionals. Family often can have a difficult time coping with the complex disease and the ramifications associated with the illness as well. So the healthcare provider must keep that in mind. A newer therapy is called cognitive enhancement therapy, or CET, and it combines computer-based cognitive training with group sessions, which allows the client to practice and to develop social skills. So the approach is designed to remediate and to improve the client's social and neurocognitive deficits, such as attention, memory, and information processing. The conventional or first generation antipsychotic medications are dopamine antagonist drugs. The first generation of antipsychotics target the positive signs of schizophrenia, such as delusions, hallucinations, disturbance in thinking, and psychotic symptoms, but have no observable effects on negative symptoms. So I have the drugs listed here, some of them, and we did review these drugs in our Chapter 2 Psychopharm lesson, so I will not be going over the medications again, but it is important to know that thorazine was the first of this first generation antipsychotic drugs, and it produced a calming effect on psychotic patients, and I believe it was 1952 when thorazine was introduced. The atypical or second generation antipsychotic medications are both dopamine and serotonin antagonists. See Chapter 2 again for all the drugs that are listed, which we reviewed in our Psychopharm lesson. The second generation antipsychotics not only diminish the positive signs, but they also lessen the negative signs of schizophrenia. So I do have on here some things that I indicated in our Psychopharm lesson, such as Clozaril. You need to monitor this patient's white blood cell count, because of the possibility of a granulocytosis. And Zyprexa, you need to monitor the patient for hyperglycemia, or this could possibly cause diabetic effect in your patient. And we have Abilify listed here, but Abilify is actually the first drug of the third generation, and it is not a second generation antipsychotic. I just didn't want to make a separate slide for one drug. So Abilify is the first drug of the third generation of antipsychotic medication. So the clinician should perform an AIMS assessment, or a normal involuntary movement scale assessment, baseline before starting the medications, these antipsychotic medications, as well as at periods during the medication administration as it's building up in their system, and just periodically throughout their treatment. So what the clinician is looking for is any new abnormal movements that could possibly be associated with the start of this medication. So oral facial movements are something that we definitely look closely for. I want you to remember that tardive dyskinesia is a symptom that is irreversible. And in your textbook, it does tell you exactly what should be done in the event that your assessment shows different characteristics. So for tardive dyskinesia, the medication is discontinued immediately. All right, so here are some extraparietal symptoms, which we reviewed, I believe, last week in our lecture, so we will not go in depth with these as well. But I did just mention tardive dyskinesia and the importance that this is an irreversible effect of antipsychotic drugs, so the medication must be discontinued immediately. That is very important for you to know. So, pseudo-Parkinson syndrome. So the patient does not have Parkinson's disease, but it's the drug-induced Parkinson's, and it causes like a shuffling gait and rigid muscles. So just think of Mr. Burns on the Simpsons show. That is like the pseudo-Parkinson's, what it looks like. So we're not going to go through each and every one of these, but dystonia is one that you should know. Spasm of neck, back, jaw, extremity, eyes, throat, and tongue. So just on your page 263 in your textbook, it talks about the Ames scale, and it does actually mention these different symptoms here. So you may give anti-Parkinson agents or anticholinergic agents to counteract the EPS or the symptoms. And sometimes a Benadryl or Ativan or Cogentin is the anti-Parkinson medication of choice, may be used in order, so they call it the ABC, may be used in order to get the symptoms under control. So for most of these symptoms, it would just be treated with the medication unless it is tardive dyskinesia. And in that case, we are stopping the actual drug and trying to find another drug that will be more receptive to the patient's body. So I've taken this table straight from your textbook. This is table 16.2. So it goes over the side effects of antipsychotic medications and the interventions that are associated with them, as well as at the bottom it lists anticholinergic drugs and the intervention. So what is our desired nursing outcomes for our schizophrenic patient? So we want them to be able to relate to others, to recognize distortions of reality, not to harm themselves or other people, to perceive their self realistically, to demonstrate ability to perceive environment correctly so that they're not thinking like someone's out to get them or watching them or listening to them, maintain anxiety at a manageable level, relinquish the need for delusions and hallucinations, demonstrate ability to trust others, use appropriate verbal communication and interaction with others, perform self-care activities independently. So these are the outcomes that we want for our patient after they have had their psychotherapy, they have had the psychoform medication, and we have done our nursing interventions. We want them to come out as mentally healthy individuals that are productive in society and able to have meaningful relationships and that are emotionally stable. Here is some education for the client as far as the side effects and managing them. So you want them to use hard candy to help with the dry mouth, but you want that candy to be sugar-free as well as any drinks to be sugar-free. Water is preferred, which will help with the constipation that may develop, as well as increase exercise and increase the fiber in your diet. So all those things with the water and the healthy diet will help with the weight gain signs that comes along with some other antipsychotic medication. Stool softeners are allowed, but laxatives are not, and the patient may want to use sunscreen to prevent their skin from burning. The client should rise slowly to prevent orthostatic hypotension. If they feel any dizziness, they should wait before they begin walking. They should monitor their sleep patterns and make sure that they are not performing any dangerous activities such as driving, operating heavy machinery while they are feeling drowsy. If a dose of antipsychotic medication is more than 3 to 4 hours late, then they must wait till the next dose and omit that dose. If they have difficulty remembering medication, they should use a pill box or use a chart or a calendar to monitor the medication administration, because this medication must be taken daily, same time, and consistently. In conclusion, let's talk about self-awareness. So the client may suffer from numerous relapse or repeat hospitalizations, and this can be very frustrating to the nurse. And the suggestion is for the nurse to acknowledge her feelings, recognize that this is a chronic illness like any other chronic illness, and that he or she cannot take the patient's success or failure at medication compliance or becoming stable in their emotional state personal. So the nurse may need to speak with a colleague that has more experience, get some suggestions on how to deal with the frustration if in fact he or she is experiencing a frustration. So I also want to emphasize that safety is our number one priority for our patient, and that's every patient, not just our psychiatric patients. But with our psychiatric patient, you must assess for suicide, intent to harm themselves, intent to harm others. So you also have to be cognizant of their behaviors if they are becoming more impulsive or aggressive. So you just want to make sure that you're safe, your colleagues are safe, your patient is safe. So you do not want to ever be in an isolated area. You want to make sure you're in an area where staff members can see you as they're passing by, or you may ask a colleague to come and sit in while you are completing your assessment for this patient if you are feeling that the patient is escalating or becoming aggressive and you do not feel comfortable. Please do ask a colleague to sit with you as you complete your assessment.